Game over. It is game over.
Game over, cancer.
I'm Val Solomon, Director of Program Impact at Cannonball Kids Cancer Foundation.
And I'm Dana Nichols, Executive Director of CKC.
Game Over, Cancer, a podcast dedicated to exploring conversations about pediatric cancer research, solutions, and inspiring family stories.
We're a nonprofit dedicated to creating innovative treatment options for kids fighting cancer and educating for change.
By creating a space for these conversations, we empower the community to take action and provide tangible hope.
Game over, cancer. Screw you, cancer. Well, today's episode is all about incorporating patient experience into research, and sometimes that patient becomes the researcher. Now, I was in Chicago at a very, very large conference and sat down for a moment next to a stranger, but as my team knows, no one is a stranger to me
for
for
very long.
So I started talking to Dr. Annalynn, and it turned out that she's an epidemiologist, but also was a survivor and actually had already been on the path to become an epidemiologist before her diagnosis. But her own cancer journey really moved her onto a track of oncology. She was so awesome. And again, I was like, this is the person everyone needs to meet. And thus came back around and said, do you want to come on the podcast?
Yeah, that's how we get a lot of our guests, by the way, is just we have all these like really amazing conversations out in the community. And then we're like, would you like to do this on film?
Yes.
Like, can we get this recorded? And then other people can see it. And I'm really excited about this episode. And I learned a new phrase.
Yes.
Called survivor scientist. Sometimes they will call it embodied researcher. But that's when you have a cancer survivor that's doing the research themselves. And I thought that was amazing.
She
and I love the term.
is so great. And I think when you listen to Annalynn, you hear a genuine warmth and kindness and curiosity. And I think that's what everybody in this field needs to be in it for the long run, especially that curiosity piece. But the first person experience she brings clearly floats through in all she does in a really beautiful way.
Yeah.
So we hope you enjoy this episode. And here we go. Well, she's an assistant professor of surgery in the Division of Supportive Care in Cancer at the University of Rochester Medical Center. She earned her PhD in epidemiology from the University of Rochester and completed postdoctoral fellowship in pediatric cancer control at St. Jude's. Her research focuses on cancer-related neuropsychological and psychological effects in survivors of pediatric, adolescent, and young adult cancers. And she's currently studying accelerated aging in Hodgkin's lymphoma survivors to inform targeted interventions. Additionally, she herself is a cancer survivor. We're going to get into all of it. Please welcome Dr. Annalynn Williams.
Welcome.
Hello.
Thank you so much for having me. I'm excited to be here.
Good. I think we make the joke every time. It's like not awkward to hear about yourself for a 30-second rundown before you're able to start talking.
It's a great way to start.
It's odd. That's true.
It is odd.
But thank you for bearing with it. So let's have like really fun, great, interesting dialogue.
Yeah.
Now. Not
Go.
awkward. Go.
When we were preparing for this podcast, though, you and I chatted, and you have a really great disclaimer before we get into some of our talk about survivorship and side effects for cancer, and it's patient informed. So we would love to hear your disclaimer for anybody listening who is a survivor of what they might hear and what they're not going to hear.
Yeah. So, when Val and I met and we're talking, I shared with her that, a lot of what I do focuses on the long-term effects of cancer, specifically pediatric, adolescent, and young adult cancer. And sometimes I think it can be really overwhelming to sit in the audience and hear about all of these things that may or may not happen to you. And I like to start my talks now by saying that I'm right there with you. I see you. And I see all the providers and other people listening to this podcast that, care so much about these patients and survivors. And I just want to say that, whatever we might talk about today is at the group level, right? So the data I'm going to talk about and mention is from really large population-based studies. It doesn't mean necessarily that it's going to happen to you, but I do recognize the anxiety that it may induce because I myself have been there to experience. And I shared with Val that I'm forever thankful for the survivor that came up and shared this with me and made me realize that I should do this. I had given a talk at the Global AYA Congress where I was talking about, the likelihood of premature mortality in adolescents and young adults that had had cancer. And I very much so had my scientist hat on and didn't realize there were many patient advocates in the audience. And this very brave young woman came up to me afterwards and shared with me how it impacted her and how it had affected her. And then I had a chance to reflect back on my own experiences as an audience member and survivor. And I was just really taken aback by the fact that I had a similar experience to her in the past, but hadn't yet realized that I had the power to do something about that. So now I do like to begin a lot of my presentations and things like this with just this disclaimer of that I realize it can sound very anxiety inducing and scary. But again, we're talking about large groups of people. And it's not necessarily a guarantee that anything that we're going to talk about today might happen to any individual per se.
And then on the flip side of that, though, you also have shared that it's important to survivors to understand the kind of impact that their treatments may have down the road, that folks are really, really interested in hearing a lot of your data. So I think it's really wonderful, number one, that you start with that disclaimer just to let people know, one, your truth and your story is important and you should share it because it impacts others. And also that, we're going to have a conversation about some really difficult things. And it's also information that survivors want. We just need to be very careful and just intentional about how we share it. So we appreciate you bringing that. And we were prepping. She was like, I do a disclaimer. And I was like, well, let's put it up front. Let's do it. I love a good disclaimer.
I do too. And I also love, we talk a lot about this idea of families, if it's parents, if it's young adults, and then as survivors, having to be an advocate for yourself, good, bad, or otherwise. But what it performs or leads to is this, where someone can have a really beautiful conversation that helps themselves and others many, many times over is really cool.
Yeah. I mean, I think back on that moment and I'm so thankful to her. And she was so brave to come up to me and have that honest conversation. It really, it's something I'll never forget.
Yeah.
Well, wherever you are, thank you. That's amazing.
And if you're a person who doesn't know if you should be an advocate, if you're, for yourself or for others, that there are so many people who are receptive to feedback and want to hear it and certainly come with I always use the phrase radical candor, like come with a kindness, but look how good that can be. So if you're worried about doing that, I would give anyone in the audience who needs permission to be an advocate to do it.
Yeah.
Absolutely. I completely agree. And I think especially in the pediatric cancer space, people are so open to feedback and so welcoming to that conversation. So especially in this space, don't be afraid to do it.
Yeah, I love it.
So your research and our topic today is pretty much about survivorship. And I thought maybe it would be great to frame our conversation in terms of survivorship research. And can you talk to the audience a little bit about why survivorship research is having a moment right now? Like what has historically, I guess, led to this line of inquiry happening now versus before? And what are we facing right now as a whole in survivorship research, just very generally speaking?
Of course. I mean, there's so much to say in that prompt. But, I think when we think back on the history of pediatric cancer specifically, right, we've made enormous strides over the past several decades. So back in the 1950s, the overall 5-year survival was somewhere around 25%. And now it's up over 85% across all cancers today. But for some cancers, that's above 95%, right? So for the longest time, we did not have the luxury of thinking about what was next, right? We didn't have that luxury. We had to focus on keeping people alive and finding those cures. That was it. That's all we had time and the luxury of even considering, right? But then we got to the late 80s and early 90s. We started to do, combination therapies, and that's when survival rates really shot up. And I think that's when people first began thinking like, for the first time, we're keeping 85 or, 80% plus of these patients alive. And they have decades and decades and decades of life to live. And it was kind of like all of a sudden this light bulb went off like, oh gosh, what's next, right? Because we know that a lot of the chemotherapies we use, the radiation, a lot of these treatments aren't cancer specific, right? So we know that they're really, really effective at killing the cancer, but they can also cause damage to the surrounding tissues and organs and things like that. And the wonderful thing about children, about young people who are still developing, is that they're so biologically resilient, meaning that like their body can kind of snap back from all of this and do really great. But what we're slowly finding out is that lasts for a certain period of time, and then it starts to kind of become more vulnerable again relative to their peers. So, we're finally at a time where we have these really high survival rates, and we now have the privilege and the luxury of being able to understand what comes next. And the importance of that is it's of critical importance, because if we can understand what comes next, then we can go back to those therapeutic regimens and change them to prevent those things. So, I think the best example of this is the use of cranial radiation in acute lymphoblastic leukemia. So, that's a tumor that can involve the brain, and we found that the cranial radiation was really, really effective at minimizing how much cancer was able to take a hold of the brain, right? But almost immediately they noticed that those children had a lot of problems with their memory and their attention. And when they went back to school, they struggled. So almost, as soon as we could, as soon as we had the right regimen, everyone said, we need to get rid of cranial radiation, right? So now we're doing stuff like that with, heart disease, pulmonary disease. We're going back to the drawing board and saying, okay, 15 years later, we're finding heart failure from, this is associated with this specific drug. So how do we go back to that regimen and dose reduce that drug or get rid of it altogether? And I think the most recent success story of this is in Hodgkin lymphoma, the latest trial that was it was actually led by SWOG, but co-enrolled with the Children's Oncology Group, so enrolled people ages 2 to 89. And they basically got rid of radiation in that trial. So the risk of secondary breast cancer from Hodgkin lymphoma, which used to be pretty significant, if they move forward with this regimen, will be almost non-existent. So this survivorship work is so, so important because it feeds right back into the treatment development to say, how do we make these things safer, right? How do we guarantee what we call a good health span, not just lifespan, for these survivors?
Mm-hmm. I mean, it couches so well with what we do at CKC, where we're talking about creating treatment options for kids fighting cancer where there either are none or there's high toxicity. So what does it look like to change the treatment option for a child to remove the toxic nature? We want them to survive, but we also want them to thrive. So that quality of life piece. So we're at this really important time frame in cancer research where for at least, pediatric and young adult AYA cancers, we're looking at we can get some of these kids post-treatment and for years. And then what does their life look like? And then what does their quality of life? Are they able to do the same things that their peers are? And so this is super important. And your research in particular is a great example of some of the things that we're learning about side effects of cancer treatments. So can you talk a little bit about what you are investigating?
I would love to. So what I'm investigating broadly, we refer to as a premature or accelerated aging phenomenon. And what we mean by that is we kind of know what's associated with aging in the general population, right? You start to develop different chronic health conditions like high cholesterol or high blood pressure or, arthritis, stuff like that. And what we started to notice in the survivors of pediatric cancers was, compared to their siblings and compared to their peers, they developed those aging-related conditions sooner, about a decade sooner. So we started digging a little bit deeper into this, and it turns out that they actually demonstrate a lot of different phenotypes and biomarkers that we typically associate with older adults. So there's something called this concept of frailty, right, which we can measure a number of different ways, and it's associated with an increased risk of things like hospitalization, dementia, mortality, et cetera, in, adults 65 and above. And, what myself and my colleagues at St. Jude, like Kiri Ness, have demonstrated is that our survivors of childhood cancer, who are on average about 35 years old, have the same prevalence of this frailty phenotype, this subclinical phenotype, as adults 65 and older.
Wow.
So it's kind of this phenomenon that they're aging presumably at a faster rate than they would have if they hadn't had cancer in the past. So, and again, I don't say that to scare anyone or induce any sort of anxiety, because it is such a small fraction of the survivors. But it still seems to be this very real effect. So what we think is happening, as I mentioned earlier, we're treating these patients during this period in their life where they're still developing, which has a lot of great benefits, right? Because they're really resilient. They can bounce back really, really quickly. But we also think we're just imparting these like really, really small molecular changes, like really tiny things that persist over time and accumulate over time like they would normally, but it's just starting much earlier in them than their peers. So what we're working on now is trying to first figure out which treatments are most associated with these, aging kind of phenomenon. And what we're finding is a lot of the time it's chest radiation, which is another reason that the latest Hodgkin lymphoma trial omitting that is just so wonderful.
Mm-hmm.
So, we're trying to tease out like, what are the real risk factors treatment-wise, so we can go back to the drawing board there and try to minimize those. But then also people are doing really wonderful work centered around interventions to try to mitigate this, right? Because if we can look at some of these biomarkers and phenotypes right when they're done with treatment and we see these kind of signals, we can say like, oh, well, come on over here with us and we're going to do this resistance band training, and we're going to get you back on the trajectory that you should have been on. For example. So I think there's so much hope here because we are learning so much that I think one day we're going to be able to just mitigate this altogether. And I think it'll be soon.
That's so interesting. I mean, I think that's where the fear comes from, is when you impart that knowledge, but then we don't have right. You're aging faster. Sorry. But to hear that you can go back, I mean, and you're an epidemiologist. So you're then in your research, as you're finding these things out, informing folks who are doing the treatment, hey, you might want to change this if you'd like to avoid those outcomes. But also it's really cool that you can run a test and figure out what kind of preventative measures or, what kind of mediation you could do with patients to figure out how to help them now too.
Yeah. I think it's fascinating that you're really talking about work that can help in so many spaces, right? So you're talking about work that helps anyone who in the future is, diagnosed. But for those that are diagnosed and in treatment now, it's easy to be fearful of like, oh, that's what happened. I'm a lost cause in that sense, but not at all, right? So again, these are little kids sometimes, or even as a young adult, you have a lot of a runway to be able to change maybe whatever can be done medically, lifestyle, all those things to sort of course correct as much as possible is really beautiful. Like, I mean, that's to me a win-win-win.
That's what we're all working towards.
Yeah.
We all have our kind of piece of the puzzle. Like, I don't necessarily run the intervention trials, but I do kind of this characterization work that helps them figure out how best to target that intervention, right?
Yeah. Well, I think, just the way where you have a disclaimer as you talk about what you speak in public, I think for survivors that are coming on, or for anyone that is talking about how the impact of survivorship research is on the patients and the survivors themselves. I wondered if we could dive into that, because I think that's a disclaimer on steroids, so to speak, of like, you're being part of this and finding this out.
Yeah, I think, it is so interesting. I call myself a survivor scientist. I've heard other folks use the term embodied researcher. And I think a lot of times you almost feel like this like existential feeling, like even as you were saying that, I kind of feel like I left my body for a minute and I was like standing over there. Because I do think sometimes it's like, first of all, like, wow, I'm really here doing this. Because I actually had started my master's in epidemiology before I was diagnosed. So I was diagnosed as 22 at 22. So I was a very young adult. I was living at home. I just started my master's. I knew I wanted to be an epidemiologist, but I hadn't really considered cancer yet. So obviously this has, vastly informed my life trajectory. But there were so many times, I went through about 3 years of treatment, and there were so many times where I, quite frankly, was like fantasizing about what life could be like after, and like picturing myself here doing something like this. Right. So in these moments, it can be really emotionally overwhelming to kind of just step back and be like, this is what you fought so hard for and you made it, right? Like
Right.
you got here and you need to take a moment and enjoy that. And then there's other times where things just hit a little too close to home and you need to take time for yourself to process that. So, in this work, we talk a lot about second cancers and the risk associated with that, especially if you've had radiation, which I had because I had a stem cell transplant. So I had total body radiation. And a year and a half ago, I was diagnosed with a second cancer. So that was like a period of like, oh my gosh, like I am like, I'm looking at this curve I made of like the number of conditions. And I'm like, oh, I'm right there on that curve. And it can be really overwhelming because it reminds you of like again, and I think this is where the disclaimer comes from, because sometimes it is you, and know that like there are a lot of us and we're all here together for you, but a lot of times it isn't you and it won't happen to you. And I have to remind myself of that, like, okay, you've had a couple things that you study happen to you, but not all of the things will
Right.
happen to you.
Yeah.
It's going to be okay.
Yeah.
Right. So sometimes it's wonderful and beautiful, and these connections you make are so amazing. And then other times I really have to step back and give myself that space to process and grieve in some ways, and just like not be okay. It's okay to not be okay.
Yeah.
Yeah. You spoke about that a little bit recently at one of our events where you were talking a little bit about sometimes it's the information that that's
Right.
scarier, that like if being in at CKC and just knowing what we know and talking to folks like you and knowing what you know, and it's just sometimes it's all the information that you have that you're constantly thinking about, that you're just like, it's too much. And if only you could step out and not know what you know for a little bit and get a little bit of a reprieve, right?
Well, and I think too, the thing about research and specifically one of the things we were talking about in that event and speech was with my diagnosis came with a genetic marker that will be passed down to my children. And yet that's pretty much where the research stops for that. Mm-hmm. And so what do you do when you know a lot more than the average bear, so to speak, but you know that we don't know enough to do what we do? And so I think that's the whole point of investing in research, is it takes us further. Research, and what I'm scared about today is because of what we know now, and that could be different in the future. But it's hard. And I think even you and I met at a cancer conference, and we're both there for work. And at the same time, sometimes I'd pass something and I'd be like, you know what? Don't look at that one. Like, just keep walking, because it's a conference is beautiful and exhausting on its own. And then you're there for work and you're doing this. And then you're also a human being trying to figure out how you're moving forward in life. So we always say, like, knowledge is power. And also sometimes knowledge is really scary.
I agree. And I think, it's all about figuring out kind of how, like, where your comfort zone lies. It's funny. I I hadn't noticed till recently. So I'm a survivor of leukemia. That was my first cancer. And I hadn't noticed until somebody pointed it out recently. I've completely avoided leukemia in my research.
Mm-hmm.
And I'm like, oh, that must have been a boundary I created for myself, right?
Yeah.
Like I've avoided leukemia, I've avoided transplant. I've focused a lot on lymphoma and then, the entire pediatric population. So somebody pointed it out to me and I'm like, oh gosh, I think, you're right. I think that was a boundary that I created for myself without even really realizing it.
And you know what? Someone else doesn't want to study lymphoma and they have dived straight into leukemia. And so it's all going to be a balance, right?
Yeah, absolutely. I think there's not enough people doing research. So there's always room for other people, and whichever part anyone's able to take on for a long term, which you really have, right? Is really cool. Yeah. And I would assume in some ways it feels like every time you learn something new, it I would hope is exciting, like, oh, we're just getting started. But I wondered what you're thinking at this point in your career when it feels like, to me, you've been in it for a long time and it could be lots more time.
Yeah, I do kind of feel like I'm right in the middle. The folks of us who do this type of work go through so much training. And now I'm 3 years into my first faculty position. So I do kind of feel like I'm smack dab in the middle of this journey. So I do feel like there's so many more things to do. And I think sometimes that's part of the struggle too, right? Like I think everything is so interesting and I want to help so much with all these different things. So sometimes it's really hard to pull back and say, well, Annalynn, reminder, you're not going to be able to accomplish this if you commit yourself to these 10 other things. So you got to kind of hone it in. But, I think, this concept of aging in our very young survivors is truly, I think, critical. And just, it's really exciting to me right now because of what I mentioned earlier, right? Like, first of all, we're learning so much about what's happening, but what we're also learning so much about is how we can mitigate it and change those trajectories. So to me, that's really exciting because like you pointed out earlier, we have a solution there. And then the other thing I'm really excited about and really passionate about is this idea. I mean, I have a lot of data to support it, so idea is a very weak word for this, is that even survivors who were treated with therapies that we did not, direct towards the central nervous system, towards the brain and the spinal cord, even those survivors are experiencing cognitive impairment. So that's actually like kind of the other half of my research is for so long, we've recognized that if we give someone cranial radiation or chemotherapy right into the brain, or they have, brain surgery, they're at risk for cognitive impairment, right? That makes so much sense. No one's going to argue about that. But for the longest time, we've completely kind of just brushed off all these other survivors who didn't have those treatments, who are also making complaints about struggling with their memory and their attention and things like that. So I'm really passionate about this because I think we need screening guidelines for that group. And I think that group deserves to be validated on these symptoms. And I feel like we're just now making headway. And I am one of the people that are really, pushing that boundary and pushing to get people to pay attention to this. So that's the other thing that I'm really, really excited about because I had a Hodgkin lymphoma survivor in my patient advisory board who shared with me like the ridiculous struggle that she has gone through over years to get people to take her cognitive complaints seriously. They keep blaming it on anxiety and depression, and true, like those things can contribute, right? But that doesn't negate the fact that she's really experiencing some issues and she's asking for help. And people keep telling her like, oh, you had Hodgkin lymphoma, you're fine. So that's why I'm so excited about that area is because I really think that group of survivors deserves the validation.
Yeah, absolutely.
That is so powerful. I mean, the thought of someone having to advocate and fight through their own cancer battle and then continue to advocate for support afterwards and then not being heard and then being dismissed is so infuriating to me. So infuriating. When we know, like, that's ego, right? That's got to be ego. Is that ego? I don't know. Is that ego on behalf of like people treating them? Like,
I love it. Put her on the spot.
Do you think we can edit this out? Is it ego? What is that?
Without knowing the people that did this to her, I can't say. And I'm an optimist. I always like to think that people have the best intentions in heart, but intentions are not impact.
Yeah.
So
Yeah.
but no, I mean, I agree. And that was a huge reason she joined my patient advisory board, because she was like, someone needs to know about this.
Yeah, absolutely.
Yeah. I mean, the audacity we sometimes have to just put everybody like, oh, you're fine, right? You survived, right? I think that was a little bit of a challenge, I think, in the beginning in terms of a history of survivorship research, right? Which is
Yes.
even advocating. I know some parents who've like verbally said to us, we want to advocate for stuff on behalf of our kids, and yet my child is alive. And how dare I complain about the symptoms they have and the side effects they have? And and then they get over it. I feel like the ones that we've chatted with are also still pissed, right? That their kid is still experiencing the side effects that they have, and they're mad and they want that to change for the next child. And that is incredibly beautiful. And, a righteous, angry parent is something that we need to listen to sometimes.
Yeah. And it's a force to be recognized.
Yeah.
And I think we can do this work recognizing that a significant amount of resources still need to be allocated to finding those forever cures for the last 15%, while still considering what's happening long-term to the 85%, right? I think we can do both. No one is saying that we're taking away from one by focusing on the other, right? And I think that's what us in the survivorship world are arguing for, right? Is that these are two equally important issues. And, the survivor's guilt you mentioned is so real. And it does feel so inappropriate when you first start doing this work, but then you realize that someone has to do it and someone has to stand up for this. And we can do it while still respecting those that we've lost, right? And those that have lost.
Well, and I think too, when the goal is more survivors,
Right.
And all survivors, then it's not worth it to wait until the number of survivors is greater to then start looking into something. Let's work on these, concurrently, so that there's a beautiful place for survivors to land and to thrive and to live in when they finish treatment.
Yeah, you've both mentioned this now, and I love it. Like, to survive, but also thrive, right? Like in my mind, I work hard at what I do in the hopes that no one will ever have to go through what I went through, right? In hopes that there are more people like me living longer and doing the things that they wanted to do. My hope is that whatever dreams they had as that like joyous little 5-year-old, they get to actually do, and they're not limited in any way in doing them because of their cancer treatment.
Yeah.
Like, that's my dream.
Yeah, absolutely. Any joyous little 5-year-olds who already wanted to be an epidemiologist and then get their diagnosis still go on to be an epidemiologist.
I know they're out there.
They're out there. Or you are having a singular experience and making so many more great singular experiences for other people. And both are wonderful.
Yeah.
Well, I don't know if there's a place people can learn more about what you're doing or the research you do, or want to click in with you. We'd love to point them there if that's of interest.
Yeah, I mean, I think, most stuff is on like my faculty page at U of R. You can also point people to 2 amazing resources in terms of long-term survivorship for pediatric cancer. So the first, if they're not aware of them, the Children's Oncology Group has a set of long-term follow-up guidelines that I will admit are not written for the general public. But, that is an amazing resource that you can share with your physicians, and they can, help you kind of dig through there to see what you might want to consider doing in terms of screening and things like that. And for folks that are, just kind of interested in where the research stands and maybe reading some papers and things like that, we have 2 long-term cohorts. The first is the Childhood Cancer Survivor Study, and that website is ccss.stjude.org, because St. Jude's actually the coordinating center, even though that's a national cohort. And then there's also the St. Jude Lifetime cohort of long-term survivors, and they can just go to, I think it's cloud.stjudelife.org, I think. Yeah. So both of those websites will have a whole list of papers that those cohorts have published over time on the different late effects and things like that, and tons of resources. But if they go to my faculty page at the U of R, my email's on there, and I'm happy to connect with anyone.
Awesome.
Thank
And
you.
Yeah, thank you so much. Thank you for your time today. If our listeners want to support the research we're doing, as you hear, research is everything to move this fight forward. And that's why we say research is the key. You can head to cannonballkidscancer.org and learn more about CKC.
That's right. And if you're ready to be a part of Team CKC, you can leave a podcast review. It helps us educate for change. I don't know if you knew that.
Absolutely. Review, like, subscribe.
All of it.
And thank you for tuning in. We know it takes so much to face this topic head on, but we appreciate you joining and coming to be part of our fight. So until next time, I'm Dana Nichols.
I'm Val Solomon.
And we'll CKC you later.
Join us as we transform fear into courage and turn adversity into opportunities for change.
If you want to be involved in the conversations that create change in the world of pediatric cancer, take a moment, share, like, and subscribe.